Hi, good morning, everyone. A warm welcome back to Dare to Care. For those who have joined us for the past 6 days or so, welcome back. This is the 6th day of our virtual experience, and we hope you're having fun. Do note we have an ongoing leaderboard and a contest section for participants to win attractive prizes. We have just launched a contest, so you can go and check it out. Some housekeeping before we start. Do remember to upvote your questions using the Q&A button. We won't be able to answer all questions, but in the consideration of time, your votes will help to guide us. I know there's a leaderboard contest going on as well, but do refrain from asking duplicate questions and ask good questions to the speakers. For today's session, the title is The Future of Allied Health and the Vital Roles They Play. To start off the session, can I invite Mr. Tan Ban Tong, Deputy Director, National University Health System, to give us the opening introduction. Ban Tong, please.
Hi, very good afternoon to one and all. I hope you can hear me loud and clear. Once again, on behalf of the management of the National University Health System, very warm welcome to one and all. Basically, this healthcare clusters, if you look at the slides here, it comprises of about close to 26 entities all in all right? And we are governed under two parent so-called agency. One is under the Ministry of Health, and the other is under the Ministry of Education, right? For the medical point of things, that's where Ministry of Health comes in. As we are also an academic system, right? Where our flagship NUS medical school, all this, they do come under the Ministry of Education. By numbers, we are about 15,000 strong, but if you see the statistic here, as a cluster, we serve about close to 2 million people, right, in the western segment of Singapore, right? And generally, while we are small, but we are nimble and we are being able to pool all our resources to make sure that every Singaporeans or visitors to our healthcare institution, right, are well taken care of. This just gives in a nutshell how we are all being structured, all right, under the NUHS care system, right, a comprehensive integrated one, right, that comprises both academic and healthcare. So we have 4 campuses under our NUHS umbrella, right, and underpinning these 4 campuses are the 3 critical areas of focus that we have, clinical care, research, and education. This is just a glimpse of the kind of campus that we have today, all right? This is the Kent Ridge campus. That's where I am located, all right? We also have the schools, the Yong Loo Ling Medicine, the Alice Lee Nursing, right? We also have the Ssr Students Public Health, and as well as the Faculty of Dentistry, NUS. On the western end, right, in Jurong, we have the JurongHeath campus. I think you all would have, in a way, passed through when you go close to IMM, and you'll see this very nice condo-like facility, right? Nevertheless, this is a modern concept of how we bring primary care, which is the clinics, acute care, which are all the general hospitals, and then the community care, which where the Jurong Community Hospital is. So in terms of providing seamless care to Singaporeans, you find that this is one area that we are looking at, and even in the future of healthcare. Alexandra campus, 100 over years plus campus, still in development, all right? We are renewing it, all right? But this is one of the few oldest campus in Singapore, for some of you are familiar with, right? And this is where the very first medical treatments were taking place in the very early days of Singapore, right? And I think we continue the tradition of providing good health care to everyone, even until these days. The NUHS community campus, as you look in this whole simple diagram here, serving the population in the West, comprised of community health, primary care health, which forms like the polyclinics and everything, care hub, right, which where we bring together community care plus even the step-down care, and of course the institutional care where we have all the long-term care sector coming in. Right? The polyclinic supports the primary care segment of our cluster system. All right. To date, you'll be quite familiar that we have coming up even new polyclinics to serve the population in Tengah and UT. But generally, this will be quite familiar to you, with the introduction that's coming on soon in September 21, Bukit Panjang. So each campus in our healthcare system have a very distinct role to play, right? If you would ask, what does Jurong Health Campus really represents, in this whole healthcare continuum that we are supporting, you find that other than the acute care hub, and regional hospital, it also provides high volume of emergency care and scaling community integration. Whereas, for example, Alexandra, it's a regional hospital. You developing the IHG model and test bed for new care models. So each of them are quite unique, right, in their sense of their functions and their role in that whole big NUHS clusters. So in short, it's one specialty, multiple sites. This is just a summary of how our specialties are being spread across, right? The 3 national centers, the community care, the 14 specialty areas that we are looking at here, all right, which covers all the medical, clinical, and other areas of concerns. At the end of the day, what does NUHS really exist for? I think our mission is to deliver incredible care to everyone, right? And as we shape medicines through our academic institution, we hope through all the research, education, and even all the processes and transformation that are taking place, we can slowly transform the degree of care that we can provide to our population. Of course, each of us, as we seek to advance health by synergizing our care, education, and research, we also take a very active role in partnering not only with patients, but with the community at large to help us realize the outcome that we can for the betterment of Singapore. And of course, we are driven by our 6 core values: teamwork, respect, integrity, compassion, excellence, and patient-centeredness. And this, in short, is the tricep values that we hold very dear to our heart. If you ask what are our aspirations, well, while we strive to be the best in class, and ensuring that every Singaporean receives excellent and affordable care, but nevertheless, we also are looking ahead to the future healthcare needs of Singapore. And that's where this afternoon, even as my fellow colleague paint the future landscape, it is something that we want to reassure every Singaporeans that NUHS does provide something they can look forward to in the future. And this is our narrative. Not only do we care for our patients, we also care for our people, which means our own workforce, where we help to develop them, right, to attain better skills and competence, right? And jointly with the community and patient, we also want to partner them to co-create, the future of healthcare in Singapore. And at the same time, we want to ensure that this level of care will continue to be sustained even through our generation and many generations to come. So today we provide good service and we want to delight our customer, and the transforming of service delivery to deliver incredible care every day starts from the very first touch. Not only do we want to deliver world-class results throughout the one NUHS paradigm and persona, but we want to ensure that the value will continue to flow with the community and that we will continue to use incredible tools in order to transform and uplift the standard of care delivery by NUHS. And the transformation and innovation not only takes place in these 4 priority areas that we are looking at, all right? Things like having smart wards, things like how do we prepare our people to be future ready, changing innovation, precision in health, and how do we even use robotic process automation in order to improve and strengthen the various processes and support enablers as we serve the population of the West. Right? So the desired model of care in the mature state, if you are looking at 2025, which is about 5 years to 10 years from now, can briefly be described in this, where not only personalized care flow through new SOC, but also the siting of patient, the appropriate siting of care, and how we help people to recover from their illnesses, and how we empower the population through certain digital tools that our patient can also take ownership, in looking after their own well-being. At the same time, through the community outpost, care hub and everything, we hope that people are empowered to look after their care, and hopefully through all this, we can really raise the level of end of life journey for everyone, all right? And that's where our specialty multiple sites, that I mentioned earlier, is where we can help to not only increase the accessibility, but we increase the value and the quality, right? So that is the kind of standard of care that we're looking at, in the coming 5 to 10 years. This is just a glimpse of Alexandra campus, right? While we look for all these improvement in processes and everything, we also continue to strengthen our infrastructure. So what Alexandra is what you saw earlier, in the coming next 5 to 8 years, a new campus will be developed in this backgrounds that you are looking at, right? And again, this will help to sustain and support our vision of delivering incredible care going forward. Right? The Cambridge capital itself, where I'm at now, also will be undergoing rebuilding, right, in the next 10 to 15 years, all right, to strengthen the infra part of things. As well as today, what we are doing is to put in place some of the apps that can help to promote seamless communication between patient and staff, right? For us, as a cluster over the last couple of years, right, we have been performing pretty well, right? Not to say that our fellow brothers and sisters in NHG are not, just that in terms of the patient experience, if you can look at this survey, all right, we are pretty much above the national norm, right, of how patients view NUHS as, and we will continue to strive to deliver, cutting edge medical and clinical services, as well as allied health and nursing supports. In delivering practice, right, changing innovation, I think we are quite far ahead, right, in some of the medical practices as shown here, other than in the area of cell technology, right. We are also being noted for our achievement across Asia and the world around us. We are also quite in the forefront of gastro, right? And we do have real top experts within the NUHS, right, who have been carrying this function for us, right, both in biochemistry, gastrohepatology, and the upper GIs. Endofield is also another area that we are noted for, right? So in a nutshell, as you can see, NUHS cluster, while we are about 2 to 3 years old only in that whole transformation when we came together as a cluster, I think moving forward, There's a lot of exciting things in NUHS, and certainly we would like to invite you to be part of our whole journey as we help to transform care in Singapore. With this, I end my presentation.
Thank you very much, Bantong, for sharing with us. Now we move on to the next session, which is titled Dare to Go Beyond by Yang Zi, a senior physiotherapist from Ng Teng Fong General Hospital, and Clara, an occupational therapist from Alexandra Hospital. If you realize just now and you pay attention during Bantong sharing, you realize Ng Teng Fong General Hospital is under JurongHeath campus, and Alexandra Hospital. And I see the questions coming in. You have some questions regarding the 3 clusters and that sort of thing. AH actually merged with NUHS back, I think, in 2016-17. So I think you can go and read up online, is it wiki or MOH website on the history. So it's quite interesting. It's complicated, but very, very interesting. So without further delay, Yang Zi will be up first. Yang Zi is a senior PT at Ng Teng Fong General Hospital. Yang Zi, please.
Sorry, Clara will be going first.
Oh, okay. So sorry. So next up will be Clara. Clara is an OT from Alexandra Hospital. Clara, please.
Hello. Give me a while. I'm just going to pull up the slides. Okay, I'm going to share screen now. Okay, can everyone see my slides and hear me? Yeah. Can I be heard?
Clara, yes, we can hear you.
Sure. Okay, then I'll go ahead. Okay. So good afternoon, everyone. My name is Clara and I'm an occupational therapist. I've been working here in AH since September 2019, and I'm now on the palliative ward, which deals with end-of-life care. So the purpose of today's presentation is to give you guys a bit of an idea of what OTs do, and also share a bit about my journey as training and working as an OT. And hopefully this will nudge some of you guys to consider our profession. So what is OT? Some of you guys may ask, is it about helping people to find jobs? Is it focusing on therapy in the workplace? Because occupations, or is it the same as physiotherapy, but just with a different name? These are things we hear almost on a daily basis, but it's not quite what it's about. First, maybe if I could start off with a video, it's just about a minute long. It's basically introducing OT, and it's by an OT to give you guys a bit of an idea of what I'll be talking about. So I'm just going to stop share first so that the video can come up.
People think that I'm dealing with helping people to get jobs. What I do actually is helping people get back to their normal lives after a physical disability or an illness. For example, after a stroke or an accident, so they lose some functions of their limbs, their hands or their legs. We get into people's lives, we observe what they do every day, what are their hobbies, so that we can help them regain back the skills to be able to do these things again. For example, if you are a teacher, you need typing skills or even handwriting skills. I will train them to regain back these skills that they need so that they can go back to their jobs. And I love being an occupational therapist because there are so many things that I can do. I don't just do physical rehab. For example, I can do cooking with them, I can do gardening, whatever that interests them. And these are the things that actually motivate people to get better. One of the most important qualities is creativity. It is because we have to plan treatment in such a way that it suits the patients better. I don't see myself doing anything else other than occupational therapy.
Okay. I'm just gonna reshare my slides. Okay, so I hope you guys could see the video. So I'm just gonna dive right into what are occupations, basically the core of what OT is about. So occupations refer to everyday activities that people do as to occupy their time and also bring purpose and meaning to their lives. So these include things that people need to do, people want to do, and that people are expected to do. Occupations refer to any purposeful activity that you can think of. Includes cooking, maybe playing tennis, working, studying, or even using the toilet or grooming yourself. So when OTs work, we consider how a person's physical, mental, and social needs impact on their recovery process. And taking this into account, we aim to build people's capacity to participate in activities and roles that are meaningful to them, and also achieve the goals that are most important to them. So in doing this, we hope to maintain or enhance people's health and well-being. We work with people with a range of conditions, including those with physical disabilities or mental or social difficulties. And these could be a result of accidents, illness, or aging. Conditions that we see in patients sometimes include cerebral palsy, stroke, schizophrenia, cancer, dementia, or even fractures from falls. And the list really goes on. So we work with all age groups in a wide range of physical and psychosocial areas. You can find us at nearly all points along the continuum of care, from the ICU to home. So you can find us employed at places like acute hospitals, where people are more acutely sick, at community hospitals, where people are a bit more medically stable but need step-down care, or at daycare or day rehab centers. You may see us doing activity engagement at nursing homes and hospices, doing rehab or caregiver training or equipment prescription as part of home-based services. You can find us at private PEDS clinics as well. And many OTs work as educators and consultants too. So these are just some examples of areas that we work in, not exhaustive, but just for you to get a bit of an idea. So maybe in stroke rehab, you might find OTs doing physical and cognitive retraining to make up for deficits from stroke. In palliative care, end-of-life care, you may find us doing things like engagement or legacy work for quality of life. In dementia care, you may find us doing things like cognitive engagement or reminiscence therapy. And in mental health, you may see us equipping people with life skills to cope with their roles and routines despite their mental health conditions. So in pediatrics, OTs may do training of skills that children need to do things like participate in play in school. In burns rehab, you may see us doing splinting or working through body image issues with patients. You may see us doing driving assessment and rehab as well. And in orthopedic rehab, you can see us training people to cope with self-care in a more modified manner to ensure that they remain safe after injury or surgery. So OTs rarely work in isolation, and you can usually find us as part of a bigger healthcare team, including people like social workers and care managers, or even PTs, STs, diagnostic radiographers, and more. So for every person that we help, OTs think about these three keywords: person, environment, and occupation. So we think about how well a person can participate in their chosen occupations in their current environment. For example, in the task of making a cup of coffee, person factors that we might think about is, does the person have enough strength, or do they have the cognitive ability to sequence the task for themselves? Environment-wise, we may think about how accessible is the kitchen, their surroundings, are the items within reach for them to carry out this task of making a cup of coffee. Occupation-wise, we will think about the task itself, like, is the task easy enough for them to complete? So we focus on achieving a better fit between these person, environment, and occupational factors to make sure that they are able to participate. So the part where all three of these merge together is where participation happens and the person is able to do the task. So disabilities can really affect your ability to do these things that are meaningful to you. So for example, if you had a stroke and now you have zero strength on one side of your body and you're wheelchair bound, person-wise, now maybe you don't have enough strength to stand up to do the task of coffee making. Environment-wise, maybe now that you're wheelchair bound, the kettle and the coffee powder are out of reach and you can't reach it anymore. Occupation-wise, maybe the task has too many steps for you now that you get more easily fatigued after your stroke and you're not able to finish it. So now that you can see there's not a good fit between the person, the environment, and the occupation, and this is where we come in. So when OTs come in, some things we might focus on doing for a person. We might do things like retraining the strength in your stroke-affected arm, working on your core or trunk strength so that you can sit upright for the task. Environment-wise, maybe you might try to ask your family to place items more within your reach, or maybe put some non-slip mats below your cup so that you don't have to use so much arm strength to hold the cup in place. Occupation-wise, with regards to making a cup of coffee, we might try to cut down the number of steps for you to make it less tiring. For example, using 3-in-1 coffee instead of making it completely from scratch. There's a bit of a process that we think about whenever we see a patient. Maybe I'll just quickly breeze through. So this is called the OT process. Usually at the start, we assess the personal and environmental factors of the patient in the assessment. Then we move on to setting goals with the patient or the family. So asking them what they want to do, how do they want to complete it, and by when. Next, we plan our treatment to be carried out, and then we execute the intervention. We also use a bunch of outcome tools to evaluate how effective our interventions are in meeting the goals and how effective we are in increasing the quality of life for the patient. Lastly, we also monitor the patient's progress and monitor if their needs are changing so that we can adjust treatment accordingly. So now I'll be sharing about my journey as a junior OT from education to my first 1.5 years of work. So I graduated from RJC in 2014. I joined the final batch of students to undergo the NYP degree conversion program. So meaning 3 years NYP and our final year in university. For me, I did my last year in Glasgow Caledonian University in Scotland. So in NYP, we were equipped with quite a wide range of knowledge and skills to be applied in our work as OTs. We learned things like anatomy, physiology, biomechanics to learn about how the human body works and the principles of movement and activities. We learned about manual handling, like how to facilitate movement, like getting people out of bed, transferring them from place to place, helping them to walk as well. We also learned about communication skills and counseling so we can interact with patients better. Also learned about mental health conditions and psych. And basically it's about learning how to treat people with these conditions. So we also learned about how to modify self-care activities like dressing or showering, using different methods and tools to help our patients cope with disabilities. We learned about pediatric conditions, about the lifespan, and skills that kids need to function. We also learned about how to prescribe and use assistive devices like long-handled reachers for clothes, powered scooters. We also learned about universal design to make homes and community more accessible for people with disabilities. And for hands, we learned about treating hand-related conditions like injuries through exercises or even fabricating splints, as you can see below down there. So the World Federation of OT mandates that students usually need about 1,000 hours of clinical practice in at least the acute setting, mental health setting, and the community. So our school was very mindful in assigning us placements that make sure we meet these requirements, and so will the uni you go to. So in my experience, my acute clinical placement was done at SGH in the neuro department. For mental health, I went to St. Luke's Hospital in the inpatient dementia ward. And for community, I was at Tan Tock Seng Rehab, as well as Touch Home Care. So these gave me a first-hand experience of working as an emerging OT in these places, also getting a feel of Singapore's healthcare system. And these were honestly the most memorable times in my education journey. So I did my last year at Glasgow Caledonian to get my degree with honours. And it was a bit more theory focused over here with a large amount of time spent doing assignments like our honours thesis. We also learned about how to critically analyse healthcare policies, both in the UK and overseas. But what was, I think, the most fun was the clinical placement, because mine was in a nursing home for people with dementia, and it was built within an actual house, like a bit of a mansion, and it was very homely and very different from the nursing homes you see in Singapore, which are very institutional. And also living overseas, we picked up quite a bit of independent living skills of our own. And some of my happiest memories were made there as well. So after graduation came the start of work, and I did, and as all of you will have to as well, I did my start of work under the conditional registration framework. So we call it CREG for short. And it's a period of supervised practice that we get to, so actually all healthcare professionals like PT, OT, ST will need to have a period of supervised practice in our workplaces before we become fully licensed. And this is when we are CREG. So this period of supervised practice is to support our familiarization with local healthcare systems and practices, and also to allow for assessment of our performance to make sure that we meet the standards of fully registered allied health professionals practicing in Singapore. So typically, if you are trained in Singapore before, you might expect to get about 12 months of supervision if everything goes well. For a foreign trained allied health professional, you might get about 24 months of full-time supervision in your full-time practice before you get your full registration. And every therapist will be assigned at least one supervisor within the organization who will see cases with you, who will debrief you and have discussions, and also do regularly scheduled evaluations to ensure that your practice is up to standard. So coming to OT, I first believe that every patient has rehab potential and every patient can be so-called treated. But when exposed to a wide range of illnesses and disabilities, I realized that not every patient needs to get better per se, especially in palliative care, end-of-life care where I am now. And in cases where patients are not expected to make much clinical recovery and may even be expected to deteriorate over time, OT still has a role in helping them to cope with deficits that cannot be corrected and maintain their quality of life as well. And before starting work, I thought maybe we'll just be expected to liaise with PTs once in a while. But honestly, we do a lot more interdisciplinary collaboration on a daily basis. So we have to communicate very closely with PTs, social workers, doctors, and nurses all the time. We work together very closely and we negotiate with one another to achieve shared goals for patients, which is quite fun. And lastly, I thought maybe OT would be very focused on training people to carry out their basic self-care like dressing, toileting, showering, but occupations extend so much further beyond that. You have people, they include housework, actual work, your actual jobs, leisure, and the list really goes on. So especially in the palliative ward, there's really so much more to occupation. And sometimes near the end of life, when being able to care for yourself independently is no longer possible or it's no longer the priority for you, oftentimes patients prefer to spend their remaining days engaged in leisure activities of their choice. We do things like gardening, playing mahjong, shopping at our mini-mart, and chasing chickens. Okay, so some challenges that I face as a student and that you may face as well, I was keeping up with a very wide scope of theory and skills that we had to learn as OT students. So as you can see before, there are really a lot of things we have to cover, from physiology to psychology to practical skills. And it was tiring to keep up, but it was very worth it. And as a new therapist, adjusting to a new work environment and pace is something that I think everybody will experience as well. And the difference is that as a student, you're only expected to handle your clinical work and that's it. But as a therapist, you have to do things like prioritizing your day's load, doing projects, doing admin work, and so on. So in terms of case management, sometimes managing cases that are doing emotional or behavioral management is something that can be taxing, but also fulfilling when you complete it. And we also have to work quite closely with MSWs, the social workers in AH, to do discharge planning, which can be tiring as well, but it's rewarding when you see patients getting the care that they need. So as an OT, in order to help people to participate in their occupations, we ourselves need to be familiar with the demands of these occupations. So it ends up that a lot of the times we have to participate together with our patients. And so I've learned the ways of gardening, because therapeutic horticulture is quite a big service in AH, in OT. I've learned about doing art, cooking, raising children, driving scooters, and so on. And with the wide scope of OT, our work is so dynamic. There's really never a dull moment at work. And as an OT, there's really nothing more rewarding than to see patients being able to achieve goals that are meaningful to them. So some achievements can be fairly big, like going home or returning to work. But especially in PAL, we tend to celebrate the small successes too, like helping a patient dying from cancer to make one last sandwich for her son, or seeing an uncle with severe stroke being able to sit up upright to eat his tau hui finally after a few weeks. So in the process, I've also forged some pretty solid bonds with patients and their families, and this is really a really rewarding part of OT as well. So COVID, I'm just going to gloss over this part. COVID hit about half a year into my work, and it really did affect a lot of things. Maybe at the patient and family level, the circuit breaker brought about many problems for the elderly because at AH, we serve a lot of the geriatric population. For example, those elderly that couldn't go out of their house because of circuit breaker, they had decreased mobility and deconditioning and led to a lot of falls for them. They also lost some of their valid roles and leisure tasks that they used to like to do outside. And for carers, taking care of them at home, the stress built up because some families are working from home and therefore stuck with patients for longer periods of time. Or now that daycare is closed, they end up having to be the ones taking back the burden of care. And I think due to social distancing, a lot of non-essential services closed. For example, like daycare, like I mentioned just now. And there were much longer waiting times for nursing homes, community hospitals, leading to us having to sort out a lot of alternative care plans for patients. We also had to find a lot of alternative ways to continue our outpatient services, like tele-rehab or conducting rehab remotely. And of course, it was a challenge to stay motivated, especially when our team was segregated and morale was a little bit lower than usual. But we also had to find alternative ways to keep our elderly patients occupied and engaged during their stay here. So for example, our we have this program called Intergenerational Therapy, which aims to bring together our elderly patients and the kids in our preschool within AH. So usually they can meet in person, like in the photo here, but due to COVID, it went online. So our kids from preschool, from the AH preschool, had a virtual sing-along and a performance reminiscence session with our patients, facilitated by OTs. We also have volunteers engaging patients in activities outside of the wards, which OTs help to guide. And also we have virtual reality goggles that we use for our palliative ward. So we bring patients through the goggles, we bring them around Singapore and around the world so that you don't feel so cooped up inside here. And also keeping the team spirit going through our teams, though our teams are physically split, then things like having meals online, which is pretty fun. And in case any of what I've shared has gotten your interest and this may be something you want to consider doing, the question is now, how can you practice OT in Singapore? So OTs and other allied health professionals are regulated by MOH, and you need a recognized qualification in OT to practice in Singapore. So this might include either an SIT degree, basically a local degree, or one from an overseas university that is recognized by the Allied Health Professions Council. So if you want to find out which of these universities are approved, you can refer to the AHPC website. So SIT is accepting both diploma and A-level graduates, and applications for the new year are open, and I think ending in mid-March if I'm not wrong. So you can head over to the website to read up more or submit an application. If you want to consider scholarships or sponsorship as well, usually for scholarships, they may cover school fees and additional allowance, and you may be assigned to an organization in future. So you can apply through the Bright Sparks portal if you're interested. And for sponsorships, you are usually bonded to a particular organization that you choose to apply from the get-go. So, and they may give you monthly allowance and maybe sometimes extra study award for good performers. And you can apply directly to, for example, hospitals or organizations that you're interested in. And I apologize for a bit of the faster pace, but I hope this has given you a bit of an idea as to what OT is about. It's really about helping people to do things that are truly important to them. And the sky is really the limit here. And there's a saying that goes, medicine adds days to your life, but OT adds life to your days. And I hope some of you will get to experience that truly. Thank you.
Thank you very much, Clara, for your sharing. Next up, we have Yang Zi. Yang Zi is a senior physiotherapist at Ng Teng Fong General Hospital, which is part of the JurongHeath campus. Yang Zi, please.
Sure, so let me just quickly share the screen. Okay, can everyone see the screen and also hear me?
Yes, can.
Okay, so good afternoon, everyone. My name is Yang Zi. I'm a physiotherapist from Ng Teng Fong General Hospital. So today I'm here to share about my journey as a physiotherapist so far. Okay, so these are the things that I'll be going through today. So first I'll be introducing myself. I'll be talking about the education journey, then my career thus far, some of the challenges that I faced, and also how I managed to motivate myself during challenging times, and then eventually things to look out for when choosing the career. Okay, so I'm a current senior physiotherapist at Ng Teng Fong General Hospital. My specialization so far is in musculoskeletal physiotherapy, which means I work in the outpatient clinic to see patients coming in with different types of conditions such as maybe neck pain, back pain, knee pain, things like that. Okay, so just a quick introduction about physiotherapy. I'm sure most of you have already done your research, went online to see what physiotherapy is about, things like that. Okay, so the role of physiotherapy is actually to assist the patient in improving strength, mobility, relieve pain, and restore physical function. There are many types of physiotherapy, including musculoskeletal, sports physiotherapy, orthopedics, cardiopulmonary, neurological, which means like seeing patients with brain injury, seeing patients with stroke, and also geriatrics, which means elderly. Okay. So for education journey-wise, I graduated from NJC in 2008. Okay, so I completed my O-levels, 2009. So I completed my O-levels. Then I went on to national service and I did a quick attachment in St. Luke's Hospital, followed by NYP and then the SIT degree conversion. So I'll go into each component one by one. Right, so NJC, like I said, I studied there in 2008 to 2009. I took 4 H2s, I was in the science stream. I took biochemistry, mathematics, and econs. Okay, so after I completed my JC, I went on to national service. So I was a combat medic in the 1st Commando Battalion from 2010 to 2011. So I felt that the experience as a medic actually helped me to improve my medical knowledge. And then as I also attended national service, I applied to study physiotherapy in Nanyang Polytechnic. I got accepted and then I deferred my studies for 2 years until I completed my NS. Okay, so after I completed my national service, there was still a period of 4 months before I commenced my studies at NYP. Hence, I decided to apply to work as a therapy assistant at St. Luke's Hospital. So it was a 4-month stint. Then I assisted in rehabilitations for patients with stroke, brain injury, hip and knee surgery, general deconditioning, and many more. So I felt that it gave me a good experience of what physiotherapy is like. And then that helped me to learn a lot of things in physiotherapy even before I started school. I believe in the hospitals, they still have things like that. But maybe now during COVID period, they don't really allow observations, but eventually they might. Okay, so in April 2012, I became a physio student in NYP. So in school, the classes were generally split into theoretical and practical components, we first learned about the basics of physiotherapy, such as anatomy, physiology, kinesiology, which refers to how the body moves. And then gradually, as the years progressed, we went in depth about the different branches of physiotherapy, such as musculoskeletal, neurological, and cardiopulmonary physiotherapy. Then on the other hand, we also had clinical placements from year 1 onwards. So we were placed in hospitals, community hospitals, primary care settings such as polyclinics, and step-down care. So the placements ranged from 1 week observations in year 1, then to 3 week clinical placements in year 2, and then eventually 5 weeks placements in year 3, where we aim to be fully independent. Okay, so these are some of the photos of the fun times I had in NYP itself. Okay, so the top left was a photo with my clinical supervisor at SGH after the completion of my year 3 cardiopulmonary placement. And then the right side, you see all of us holding balloons. That's when we completed all our clinical placements. And then the bottom is our graduation photo. Right. So after I've completed the diploma, I started work as a physiotherapist in Alexandra Hospital. That's because I took up the JurongHeath sponsorship program when I was in NYP. So I started work in AH from April to September 2015, and then I was in orthopedics department. Okay, let me see. Yes, so I was doing inpatient orthopedics, and I was helping people who were admitted from trauma and elective orthopedic surgeries. Subsequently, I had the option to continue my studies by converting my diploma to a degree conversion at Singapore Institute of Technology, just like Clara did, but she went to another school. So I've also decided to apply for the MOHH Healthcare Merit Award scholarship. And then subsequently, I completed the 1-year degree conversion at SIT, which also included a 5 weeks clinical placement or clinical exchange in Ireland, Dublin itself. Okay, so there are some photos of the overseas exchange. So this is a famous photo of the library of Trinity College Dublin. Then we had some fun with dinner meetups with my friends who are in the same course. Of course, this is a famous bell tower, one of the most iconic landmarks in TCD itself. So for the clinical placement itself, I did it at the Teller University Hospital, which is in Dublin itself. I was doing both inpatient and outpatient. So inpatient was, I was trying to improve the physical function of patients with kidney problems in the wards. And then for outpatient, I was conducting cardiac rehab classes for patients with heart problems. So after the completion of my clinical placements, I took the chance to travel around Ireland and Europe itself before returning to Singapore for my graduation. Okay, so looking back, there are some challenges that I faced during my time in NYP and SIT. So first point, I felt that I had to battle many misconceptions about going to polytechnic instead of university. I can't even remember how many times I had to explain to my relatives and friends. So there's no such problem now, as the NYP diploma with degree conversion has been replaced with the degree program in SIT, 4 years. Okay, so another challenge was the difficulty of being proficient in both theoretical knowledge and clinical skills. So being good in your clinical practice actually requires another set of skills on top of theoretical knowledge. So there's a lot of soft skills that come with practice and experience that will help you to improve your communication with patients. So it can also be quite challenging to learn how to adapt to different situations quickly during clinical placement. So for example, sudden medical emergencies may occur. Maybe when you're assisting a patient to walk, the patient may suddenly feel faint and need to sit down. So it really tests a student's ability to react appropriately and swiftly to the situation. Okay, and lastly, going back to the part about soft skills, So I think that being a physio really entails a huge amount of interaction with people, be it with patients or fellow healthcare professionals. So as what Clara mentioned earlier, she interacts with PTs, STs, and different professions on a daily basis, and that's what really we have to do all the time. Even in outpatient myself at the moment, I also interact regularly with doctors to ask them about patients and how to provide the best care for them. Okay, so after my graduation from SIT, I followed the team and moved from Alexandra Hospital to Ng Teng Fong Hospital as the pioneer batch of staff in Ng Teng Fong General Hospital. Then subsequently, I completed my other rotations in neuro rehab at JCH, musculoskeletal at outpatient clinic, and then general medicine in the wards. Subsequently, we were allowed to choose our specialization after completing the rotations, and I chose to be in musculoskeletal physiotherapy. Since then, I've been there for more than 3 years and counting. Okay, so these are some of the photos of the different rotations I've gone through. So as you can see, even though working can be quite difficult at times, we still try to have fun on our own by organizing different things such as team lunches, birthday celebrations, and also outings. Okay, so apart from clinical work, I'm also involved in other clinical or non-clinical related projects. So these included things like quality improvement projects in order to improve certain work processes or workflows in the department. We also have interdepartmental collaboration. So for example, like we said earlier, we work with doctors to produce rehabilitation protocols after operation to ensure that the patients receive the best care. Then I was also part of the rehab welfare team that plans events for the entire rehab department in Ng Teng Fong General Hospital for the department to enjoy and relax. Okay, some people may also get to plan other events such as PT Day, Physio Day, or Allied Health Day. And then if you're lucky enough, you may also get to be involved in other things such as inter-hospital projects, which are quite good for your own portfolio and your own self-learning. Then at the same time, it is also very important to continue your own professional learning through attending talks or courses to learn skills that will benefit you and your patients. Okay, so the top left photo was taken at a spinal mobility workshop organized by SIT, which I attended, which was fully sponsored by the hospital itself. Then the bottom photo was taken at the Singapore Prevention and Cardiac Rehab Symposium in 2015. Then the photo on the right was taken after one of the rehab welfare events organized by the welfare team. Okay, moving on to some of the challenges that I faced at work. I felt that one of the biggest challenges that I had to face was to manage multiple projects in addition to a full clinical loads. So that means that I sometimes have to work into the night or even on weekends itself. Another challenge is the need to continuously improve yourself by reading up on new research papers or going for courses. So researchers around the world are always churning out new research every day. So you'll find that if you don't try to continuously upgrade yourself, what you have learned may become outdated if you don't update yourself regularly. And sometimes these reasons might cause you to have some difficulty in achieving work-life balance. But also I realized that it is quite important to understand that there's a limit to what physiotherapy can do. So same as occupational therapy, as what Clara mentioned earlier, as much as you want to help a patient to regain their function, get rid of the pain, things like that, sometimes it might be more beneficial to understand your own limit and also refer patients to other professionals rather than simply try to just solve the problem on your own. Okay, so facing these challenges, right, how do I constantly motivate myself? So I'm considered lucky in the sense that I'm really interested in physiotherapy itself, and then that has sustained me through the years. So I don't really find it as a hassle or chore to attend courses or to read up on the latest evidence. Okay. I find that it is really important to also pursue other interests apart from physiotherapy itself, such as learning new skills or having hobbies. So this will try to keep your mind fresh as you tackle the challenges at work. Thirdly, the immense job satisfaction that comes with your patients getting better cannot be replaced. And then that has always been a huge source of motivation for me to work harder to make sure that they get better. Then lastly, I felt that I really enjoy building genuine relationships with my colleagues and my patients. And then that has made work a lot more enjoyable for me. And I look forward to going to work every day. Okay, so lastly, how do you know that physiotherapy is for you? So I feel that as long as you have compassion and then you want to make other people's lives worth living, you are a team player, you are comfortable with body or physical contact, I mean, we are physical therapists, then you are willing to interact with patients all the time, you are willing to listen to other people, then you think that you are adaptable. I think that these qualities or these things will help you to become a good physiotherapist. So I hope that this presentation has given you more insight into the physiotherapy profession. So if you're interested, you can apply for the course, and I wish you all the best in applications and good luck into your future careers. Thank you.
Thank you very much, Xiangzi and Clara, for your sharing. We shall begin the Q&A session. I think we have about 30 minutes until the next session. So first question, which is on the Bantong's presentation. Will I be assigned to work in the various hospitals within NUHS, or will I remain in one hospital throughout my career?
Okay, I'll take this question, all right. Will I be assigned? I think generally the physiotherapist job in this instance is a specialist job, all right, number one. Number two, the role of the physiotherapist is no different from the role of other medical profession that involves a lot of people relationship, people factor. And that is one of the things that it is a challenge for us that we do not generally rotate physiotherapy around across hospital. You know, it's not like an engineering job or other kind of job where rotational will give you perspective of skills and capabilities, but more so we will generally keep the people who are hired within the hospital environment. But as far as career development is concerned, all right, there will certainly be an opportunity for you to have an insight into what other hospitals are doing. And this learning is generally true. Like for example, I think Yang Chu mentioned one part on this cross-institutional projects and everything. So as part of the career development, we do allow for exposure to other hospitals, more to gain insight and knowledge into the kind of challenges that different hospitals face, right? And also have a better understanding of the repertoire of what you call challenges that each hospital face, right? Because they serve different segment of the population, and because as we all know, different geographical segment do give rise to different kind of needs and everything. Yeah, so that's for the first part. The second question is, does NUHS currently have any observational attachment? I think in the past, before COVID, I think there were some instances where we do allow for students, right, to come in for some short attachment or everything. But I think in the light of COVID, I think there's a little bit more challenges, right, in terms of exposure and risk. And I think for the moment, we are actually putting all this on hold, right, until where we think that the situation stabilizes and is safe for people to come to contact one with the other. Yeah, I hope that addressed the two.
Thank you very much, Bantong. I think to add on from healthcare scholarships also, for the career, the rotation question, I think one of the things we encourage is for healthcare scholars to be in constant dialogue with their superiors or their reporting officers. There are various opportunities to develop. You can go for conferences, you can, when you see patients, you can see different age groups, that sort of thing. So I think there's no lack of development opportunities throughout your career with NUHS. And yes, echo Bantong's observation also, I think now the hospitals are really having their hands full with COVID, so there are not much shadowing opportunities for now. Okay, let's move on to a question for Clara. So Clara, we have a question, and the question is, how do you cope with the loss of patients since you work in palliative care? And another question which is linked, in a palliative ward, how do you manage to maintain calm because it's a sad situation?
Okay, so to the person who took interest in palliative care, thank you. I'll try my best to answer. So it's a very valid question because palliative is really a lot of it, the times about end of life care, and you see patients actively dying in the ward, and you may be wondering about how to cope with sadness and sadness and grief in possibly. So honestly, right, in palliative, for patients that are clinically deteriorating, there's still so much that they can do. And as OTs, we really have to tap on that remaining potential. They have to do things that they want to and that they enjoy. So it's hard to remain sad when you are focusing on helping them to do things that make them happy. And yeah, when you're focusing on bringing smiles to their faces, oftentimes you don't really find yourself feeling sadness or grief. Yeah, so in OT in palliative care, you see us doing a lot of fun things with patients who are dying. You see us pushing patients out on their bed, like bringing the entire bed out for them to get sunshine, for them to see the trees. Or you see us bring patients on wheelchairs with their oxygen tanks and their oxygen prongs to go and chase chickens outside in the garden, for example. Or we do cooking, we do art. All the things that they used to be able to enjoy before they got sick. Now we just modify it in a way that's easier for them to do when they are not so well. So honestly, there's a lot of joy that we bring to patients, and they tend to return the joy to us as well. So you'll be surprised to know that palliative care isn't really as sad as you think it might be. So yeah, I do hope whoever asked the question, maybe one day you get to experience it as well, and you may know what I mean. Yeah, so I think dealing with grief is about being mindful maybe. So it's natural to feel sad when patients are passing on or when they're passed on, but as professionals, we just need to be mindful how we empathize with patients and we work them through and help them process their sadness. We also need to make sure that it doesn't get transferred fully to us as well. We have to maintain a little bit of a filter so that we don't get so affected by it that we can't function in our work, because we are supposed to serve patients to the best of our abilities as well. And when patients do pass on, I think usually it's natural to feel sad also. It's okay because you were close to them and you did a lot of things with them while they were with you, and you had some relationships with their family as well maybe. But I think it's important to celebrate the life that they have instead of focusing on the fact that they have passed on and that they are gone. It's about celebrating the things that you could do with them, the things that you helped them to be able to do for the last time before they passed on. Yeah, sometimes families, a lot of time they come out to us and thank us for, thank you for doing things with them that we never thought they'll be able to do while they were dying. Yeah, so there's a lot of hope in palliative care and a lot of happiness as well, on top of the sadness that we feel. So yeah.
Thank you, Clara.
It's a nice experience overall.
I think to add on, right, I used to have next of kin who were also in palliative care. They have since passed on. To be honest, I echo Clara as well. I think those were the happiest days of their lives, to be honest. I think it really depends on the patient's mindset. Do they go into it feeling sad, or do they want to go into it feeling happy and making the best use of their time? So I think is a place for hope. Let's not be so negative. I think if the whole ward or the whole people around the situation, they are hopeful, there's a lot of positive energy, things can be really, really, really very different.
I think so too. I think maybe if I actually do you think I could share a quote from my colleague?
Sure.
Because it did come to mind when you were sharing about people being able to do things in a different environment. And so I think there's a quote from Hunter S. Thompson. This one was given by my colleague who was in the palliative ward before me. She's called Joyce. And it's basically that life should not be a journey to the grave with the intention of arriving safely in a pretty and well-preserved body, but rather to skid in broadside in a cloud of smoke, thoroughly used up, totally worn out, and loudly proclaiming, "Wow, what a ride." So I think it kind of ties up nicely the things that we do as OTs. We do some things that people think are a bit crazy, like bringing them out of the ward or doing activities that people think they may not be able to do, but it's totally possible if you use clinical judgment. And yeah, there's nothing is impossible lah.
Thank you, Clara. Let's move on. So I think I can answer this question. There's one question: can you work as an accredited OT with just a diploma, or is a degree required? What job opportunities are available with only a diploma? I think Serene has also answered in the chat box. The diploma with NYP has since been discontinued. So you will now go to SIT to take your OT bachelor's. But as for job opportunities available with a diploma, maybe Clara, you want to clarify, but I think you can, if you're interested in OT, for example, you can go to the hospitals and work as a therapy assistant, for example, if you still don't know what you want to do or whether to make the next step. So maybe Clara, you want to share whether that's possible?
So you can work as an OT in Singapore with a diploma, as long as the diploma is in occupational therapy. So you must be holding the diploma that was likely from NYP, because it's the only one that I know of so far. So if you have a diploma in occupational therapy or a degree in occupational therapy, you still can work as an OT. There's no difference in the job position that will be offered to you because you end up as an occupational therapist either way. It's not really that if you have a diploma only, you'll be stuck as a therapy assistant. As long as diploma is in OT, that is the important point. I still have friends and colleagues that are only holding onto diplomas and they are still working as occupational therapists. So it is possible. But at the same time, I think it might depend on organization now. So because maybe some places now are only accepting people with SIT degrees, some may no longer be accepting people with diplomas. So just need to check on a case-by-case basis, I suppose.
Thank you, Clara. We'll now move on to Yang Zhi for a while. So Yang Zhi, there's a question which says, is PT considered a feminine career? It seems like a lot of delicateness is required. Before Yang Zhi answers, right, I don't think so. I think in his sharing, he shared that he was from 1st Commando Battalion. I don't think that is considered very feminine. So maybe Yang Zhi, you want to share?
Okay, so of course, I don't think it's a feminine career. So I don't think feminine in the sense that only girls can do physiotherapy, but it should be more of you should be a thoughtful person, and then you have to exercise a lot of you have to be quite meticulous and exercise a lot of caution, when speaking with patients. Then generally you have to think through a lot of things before you administer treatment for the patient. Yes, rather than saying that it's a feminine career. But I will say that in my batch of physios, there were definitely more females than males. That's what I can say, yes.
Thank you, Yang Zhi. Another question, I was interested in musculoskeletal sports things and like to help people back to normal physical activity. So is it true that I should choose PT rather than OT?
I would say that if the person asking the question is interested in only musculoskeletal physiotherapy or like sports related things, then physiotherapy does seem like a more viable option for that person. However, I will advise the person to not be too caught up by, musculoskeletal, that's the only thing I want to do. So once you have entered physiotherapy as a profession, you'll be expected or you'll be asked to go through different rotations and then seeing different kind of patients, for example, like orthopedics, neurological, elderly geriatrics, or even palliative as well. So I'm sure that palliative itself, there are physiotherapists inside the wards as well. So sometimes after going through these rotations or these placements, you'll find that you actually enjoy them much more than seeing patients in our outpatient setting. So it really depends from a case by case basis. Yeah, so but don't narrow yourself to just sports or musculoskeletal itself.
Thank you, Yang Zi. Back to Clara. So there's a question which is, could you share more about neuro OT? Is this the same as mental health?
I had to unmute myself. Also, can you hear me?
Yep, we can.
Okay, so neuro OT is not the same as mental health, although sometimes mental health does come into play a bit lah. But more or less, neurology is more about the nervous system. So we do in neurology, I mean neuro OT, we see patients with a range of conditions to do with the nervous system lah. So spinal cord injury, brain injury, stroke, or even things like ALS or other things lah. So that's more of a bit of summary of the scope we might cover. So sometimes we do have to assess patients. I mean, in terms of interventions, we have to see whether patients have rehab potential or whether they don't. If they have potential for rehab, then we'll do more remediative things, like we'll train maybe their upper limb or their trunk, their strength, their sensation, everything. We aim for improvement in these areas. But if they maybe they have limited rehab potential, meaning that they will be stuck with some deficits in the long term, we may go for a bit more of a compensatory approach, like seeing if we can train caregivers to cope with their needs, or whether we can prescribe them equipment to help. So, I mean, because we focus on helping to function better, so even if they have long-lasting deficits, there are still other ways we can find, like changing the ways of doing the task, train them to use different methods, or we give them devices that can help them to perform these tasks better, or we do equipment prescription, like giving them specialized wheelchairs or power mobility devices, things like that lah, just to modify. And we also do a lot of things like home modification. So changing the way their home, adding things to their house or changing the setup so that they can function a bit better with their new level of function lah. Yeah, I hope that if you have any other question about it, you can also ask. I hope that was a bit of a sufficient overview of the things we do.
Thank you, Clara. Another question. So each individual has different activities they do in life, and OT must be well-versed in everything from music to cooking to gardening. So I think this question is asking, if you aren't a good gardener, for example, or you don't appreciate music, how are you going to bring the patient back to his or her activity of daily, living?
Okay, I would say, don't worry. We don't have to know how to do all these things, because it's things that you pick up on the job really, or even in school lah. Because in school, the important thing is not being good at the activities. It's about knowing the demands of the activities, what it means for the patient, what the patient needs to be able to do, what abilities they need, or what kind of setup they need to be able to perform these activities better than they already are lah. So usually, even if we don't know how to do something like canoeing, for example, which is completely foreign to us, but we still have a patient that needs to do it, what we do is we do a bit of research on our own to go and find out the demands of the task, the steps needed, what kind of muscles need to activate, for example, to do these tasks. And then we will do the training from there lah. So we don't have to be experts in the things that we train people to do, but we need to at least know what it entails for the patient so that we can tailor our interventions for them.
Thank you, Clara. I think I add on, the OT usually works on the muscle and the basic action that the person needs to do. So for example, if you're looking at cooking, right, I don't think they will need to have the best nasi lemak recipe, rather than, it's the other way around. It's more like, teaching the person to fry, teaching the person to add ingredients. I think those sort of things still can't stop a patient from cooking a delicious meal lah. But of course, if you have interest in the cooking and all that sort of thing, it will be a plus point, I guess.
Yeah, so I think even like physical things aside, we also do a lot of cognitive work as well. So even patients with altered mental function, or they have maybe decreased memory or decreased sequencing in decreased ability to sequence tasks, we also help them to work through those things to make them more functional the tasks need to do lah. And that's also an important part of neuro rehab, like cognitive retraining and behavioral management, which I forgot to mention just now. But yeah. Thanks, Nigel.
Thank you, Clara. Okay, let's move to Yang Zi. How does physiotherapy differ from other specialized fields such as chiropractics? I must clarify, right? Chiropractics is chiropractics is not a recognized allied health field under the AHPC, so you might want to take note of that. But Yang Zi, over to you.
Yes, so as what Nigel said, chiropractic is not a recognized, allied health profession in Singapore at the moment. And then I think most of them actually got their degrees from US, if I'm not wrong. And the difference mainly, I would say, is chiropractic, they believe that all the problems actually stem from the spine itself, even knee problems or like foot pain, that kind of thing. So they actually do a lot of manual therapy in order to cure things that might be, from the knee pain or ankle pain itself. So that is fundamentally different from physiotherapy. And then physiotherapy, we believe in we are moving towards a more exercise-based, more evidence-based approach, which is different from a little bit more passive kind of treatment given by chiropractors. At least that's what my patients tell me in the outpatient clinic usually. Yeah.
Thank you, Yang Zi. I think to add on, right, it's quite important because, the AHPC body is a regulatory body. I think it's important to read up on these. So do go online, read up on chiropractics and those sort of things. I think there has been quite a number of articles over the few years. Yang Zi, can you advise us on how do we achieve work-life balance, especially since you mentioned at times you have to work OT and even on weekends?
Okay, so I think it's about time management. So if there are things that you are really interested in, you will find the time for it. So on days that I have to bring, like for example, I have projects to do, I have presentations to do, I bring work home, but that's fine. But sometimes on the weekends or even on the way to work, I will try to do the things that I enjoy or like I like to do. So for example, even now, on a weekly basis, I'm taking up Japanese lessons just for my own interest sake lah. Yeah, then I go for exercise regularly to upkeep my fitness as well.
Thank you, Yang Zi, for sharing. I think past few days we have been listening to sharings from various various disciplines, right? I think time management is something. And I think from what I hear, right, there's also a fixed number of hours and those sort of things that you have to work in the week. So there is a certain guideline, so to prevent burnout, to prevent overwork, those sort of things. I think one of the more fun things is that some of them prefer the shift works, prefer they prefer the flexibility in that sense because they get day offs where they get to do things without much people in the mall, that sort of thing. So I think it's work-life balance, so that's quite important as well. Because I must emphasize, as a scholar, right, you will be studying, you will be taking up leadership positions, you will be organizing camps, you will be pretty much swamped in not even when you start work, even before you start work, when you're studying, that sort of thing. So you really have to balance your time. As I think especially in this modern day and age, right, that's even more important because of the various online virtual Zoom calls, that sort of thing. So let's go back to Clara. So there's a question here. Why do you choose to be an OT over other allied health occupations like SLT, speech language and therapy? And maybe I pose this question, maybe Yang Zi, you can answer after Clara also. So there's another question which talks about, why do you choose OT over PT? So maybe you can give like overview of both and why do you choose OT and PT for the both of you?
Okay, so for myself, I chose OT. I mean, I was considering between OT and PT actually, which I think is a dilemma that a lot of you guys will have if you're out there. I was more attracted by, I think, the idea of functionality. So because OT is about really targeting activities or roles that are meaningful to you and really getting a person back to those roles and those activities. So I think that was something that's particularly meaningful to me, the focus on functioning your daily life. Yeah, I think something that was interesting to me also was that OT also covers cognitive, perceptual, and mental health. There's something a bit unique about our profession as well. So I think seeing that we get to learn about this wide range of interventions and wide range of conditions. I think that's one thing that attracted me to OT. Yeah.
Yang Zi, how about yourself?
Okay, so for me, one of the reasons why I chose physiotherapy in the first place is because of a personal experience. So before I actually entered the course, my mom had some back pain. Then she went to see a physiotherapist, but that was in private practice. And then after a few sessions, she really got better. And then she was discharged. So I was pretty impressed with how professional the physiotherapist was. And then that kind of gave me some inspiration to want to know more about my body, and then to know how to help people regain function, relieve pain, things like that. So that was stemming from a more personal experience perspective. And then also when I first applied for physiotherapy, I was under the impression that I'll be doing musculoskeletal. I mean, that's correct, I'm doing musculoskeletal now. But I was quite narrow in my point of view that, I want to do musculoskeletal. But after going through the different rotations, or even the experience of working as a therapy assistant in St. Luke's Hospital, I came to like other branches of physiotherapy as well. And then I think actually all these experiences come together and shape my own worldview of physiotherapy itself. And then I dare say that even cardiopulmonary or my experience in ICU, that actually benefited my worldview as a physiotherapist. And then if let's say someone comes into my clinic with neck pain, but then I realize they have breathing problems, I will try to treat the other issues as well. So that is more of a patient-centered care.
Thank you, Yang Zi, for sharing. So we have another question, which is, would you recommend this course to students with no science background? Any advice for new students with no science background entering the course?
No science background, I will say that there might be certain bridging. There are things that you might have to get used to, because studying science goes with a certain way of thinking that if you're an art student, you may not be very familiar with. But to be honest, I have not applied any knowledge, biological or chemistry knowledge that I learned in JC to my physio course itself. So everything was new, but it's more of the way of critical thinking and the thought process that is important. So I don't think that art students are that much at a disadvantage. Sorry, Nigel, I think you are on mute.
Whoops, sorry. Sorry, Yang Zi, a quick question. How do you remember the different exercises to strengthen or exercise the different muscles?
So in response to this question, I'll say that you will need a very good foundation in your anatomy, physiology, and then your kinesiology, which is the study of movement. So anatomy refers to studying where your muscles are attached to, how many bones are there in the body, what are type of joints. And then physiology refers to the function of your organs, things like that. So after you got these three things hammered into you, or like you are very familiar with them, then naturally you will know what kind of exercises to give the patients, then how to prescribe exercises based on those strengthening principles, things like that. Yeah, but of course it comes with practice and experience and revision as well. Even 5 years or counting into the job, there are still times when patients come in and I'm not sure what is wrong with them. But of course, I will try my best to go home and study and read up more, or like sometimes go for courses or even watch YouTube videos to improve my so-called vocabulary of exercises to give.
Thank you, Yang Zi. Okay, we shall head over to Clara for a last question. I think we have Denise coming at 3:30. So Clara, there are a few questions on the different backgrounds, or rather, different experience with different age groups for OT. I think there's a question which says, which is the best hospital to work as an OT in SG. I know that question is quite sensitive, so I don't think I have to answer that part. But maybe elaborate more on the, the various age groups, various types of OT backgrounds. And I think there's also a question on, do you have to go for further studies such as your master's and PhD to be promoted to be a principal, PT and OT? Maybe you can take that one also.
Okay, so as for the question about which is the best hospital to work as, so far, I mean, I don't think anyone has established whether there's a best hospital or not. It's more which hospital suits your preference and your working style and maybe your goals as an OT, because some different hospitals have different focuses of care as well. If you prefer the community sector, maybe you might maybe prefer a bit more slower stream rehab, prefer getting a longer time to know patients, or and such, you may want to go for maybe step-down hospitals or maybe more community care. If you prefer maybe faster pace kind of working day, or seeing people with more acute or managing more acute medical conditions, then you might want to go for a bit more of acute hospitals as well. Yeah. And how to get very experience with different age groups, because I think, as I mentioned earlier, OTs work with people really across the spectrum, from infants to elderly, to the dying as well. So not to worry. I think during school, there's always opportunities for you to get exposure to the age groups that you're interested in, because when you're going for your placement, you can also try to make requests. If you're interested in pediatrics, you can opt for maybe a pediatric private practice, or maybe going to special schools for placement if your school so allows. Or if you're more interested in geriatrics, you can maybe, of course, there are many options that you can go for, like home care or day rehab centers, that kind of thing. You can always try to maybe consult your future lecturers for advice if you have interest in different age groups, because I think they can help you through that. Otherwise, I'm not sure if I answered that question fully, but you also, while looking for jobs in the future, if you still want to work with a variety of age groups within your workplace, there are some places in Singapore maybe that have a wide range of services. So you can look out for people, for specific organizations that have services for maybe pediatrics and also adults at the same time, so that you can get the exposure that you need in your workplace.
Thank you, Clara. Would you be able to elaborate on the education thing? Do you need a master's or PhD to be promoted?
So I think, just based on my experience, some of the principal OTs that I've seen do not have masters. I think it might not be so much of, I think promotion may not be based on the education level. It might, from different, it differs from hospital to hospital. Some are based on length of time that you've served. Some are based on goals that you have achieved and services that you provided to the hospital that allow you to be promoted. So I think perhaps not to worry about that. You can always clarify with the organization that you choose to apply to in the future as well.
Thank you, Clara. Before we go to the niche, right, maybe I add on that also. So with regards to the education portion, right, I would say that, clinical ability and, the actual surveying, attending to the patients, I think those sort of things are also very crucial as an OT. And I think don't rush the steps. So because when you eventually become an OT, you finish your studies at SIT, for example, you'll be able to explore the various settings, the career progression. And, like what she mentioned, right, there are various settings available. Don't rush. So during your time with your university, during your clinical attachments, ask your supervisors, ask your lecturers, get a feel of the different settings and what you actually want to do before you make a decision. I think it's quite important. There are quite a number of nurses or even working professionals outside of healthcare that, they go into this particular setting and they realize that, I thought that this wouldn't be fun, but this ended up being fun. So do widen your horizons a little. So you guys are, I think, A-level and diploma still very young. So it's a question for the future, I feel. But good thing that you're thinking about this now. I think we encourage you to do so at a young age also. So thank you, Yang Tze, and thank you, Clara, for your sharing. I think the students have benefited from your sharing. Right now, our next session is Exploring Diagnostic Imaging by DDI. We'll be having Denise share with us. Denise is a senior radiographer at Alexandra Hospital. So Denise, if you can share your screen and take over, please. Thank you.
Thank you. Bye-bye.
Hi, everybody. I'm just going to put up my screen now. Okay, good afternoon, everyone. My name is Denise. I'm a senior radiographer from the Department of Diagnostic Imaging at NUH, actually. And today we're going to explore diagnostic imaging together. Okay, so firstly, who are we and what is our job title? We are diagnostic radiographers and are allied health professionals. We're regulated by a body called the Allied Health Professions Council, which is separate from that of doctors and nurses. So our role in the healthcare environment is to use sophisticated medical radiation equipment to produce good quality images that can aid the healthcare team in diagnosis of illnesses or injury. What kind of medical images do we produce? So you may be more familiar with these types of X-ray images. They're produced using the conventional projectional radiography, where the X-ray beam passes through an area of interest in a patient and creates a two-dimensional image, which is recorded on a piece of film or an image receptor on the other side. So some of the more advanced methods of imaging include computed tomography, where we can also use radiation to capture cross-sectional images of the body over a set distance and obtain a volume of information. So then the horizontal images can be stacked to produce reconstructed images in different views, such as this one, okay, or to produce reconstructed images in a three-dimensional view like this to better visualize anatomy and pathology. Angiography is the imaging of blood vessels. We can look for any blockages in these vessels by injecting a special radiographic dye called contrast, which can be seen under X-ray. So the system also allows users to hide the anatomical information and just to highlight the vessels, as we can see in this picture here. Can you make a guess which area of the body this is? Those of you with really sharp eyes might have noticed a tiny clue in the corner here. Okay, it says cerebral angio. So that's right, these are blood vessels in the brain. And then we have nuclear medicine, which also uses radiation, but this requires radiographers to administer an exact dose of radioactive substance into the patient's body. And this will collect in certain tissues, and we can use specialized machines to detect areas of the body that's emitting more radiation than expected. So in this row of three images, you can see that we have combined two types of imaging to produce a fusion image. This shows the functional information from the radioactive substance. The middle picture is a CT image showing anatomical information, and the last image is a fusion of the two, which produces a PET CT scan image to more accurately identify the regions of interest. Radiographers also use imaging modalities that do not require radiation. So ultrasound employs the principles of sonar, using sound waves to locate and display structures within the body. In addition to having a look at babies in the womb, we can image organs such as this kidney or this liver. We can look at muscles, blood vessels, and also have a special kind of contrast that's suitable for ultrasound use, as we can see here in the black and orange picture. Magnetic resonance imaging, as the name suggests, uses a magnetic field and the behavior of atoms and molecules within this field to produce images. This is particularly useful in the brain and the spinal cord, but can also be used to demonstrate a wide variety of anatomical structures and pathologies. So I've shown you the different types of images that we can create, but what do the machines that produce these images look like? We use machines of all different shapes and sizes. We have small systems like this ultrasound probe in the corner, in the top left-hand corner, which is attached to a tablet. All the technology is squeezed into the handheld probe and only requires an accompanying application to perform imaging. Below that is a dental X-ray unit with a small enough tube to image teeth within a patient's mouth. And we also have, on the right-hand side, a mammography X-ray machine. This might be more familiar to you. This is a conventional X-ray machine with a standard configuration of the tube above, a floating table, and an image receptor underneath to capture the X-rays that are emitted from the other side of the patient. Some of our machines also come with wheels. We have mobile X-ray machines that we can push to the wards or the intensive care units for the patients who are too ill to come to our department for X-rays. That's shown in the middle here. And in the right-hand corner, we have a big X-ray system called an O-arm that can take X-rays during surgery. Here you can see the radiographer wearing a lead gown for safety, and I will touch more on that later. Here we have some of the bigger machines. This is an ultrasound machine, which is one of the systems that I'm most familiar with. This one on the left-hand side is a CT scanner, and on the right we have a SPECT CT gamma camera, which is used in nuclear medicine. That will detect the radiation that is emitted from the patient's body. At the bottom right, we have an MRI machine. It looks very similar to the CT scanner, but functions totally differently. And at the bottom left, we have an image intensifier C-arm that is also used intraoperatively during surgery. So this has been a really brief introduction to the technical side of what we do as radiographers and the types of machines that we use in our everyday work. And how did I get here? I would like to share my education journey with you and give you an idea of what you might learn as part of a diagnostic radiography course. After graduating from Raffles Junior College, I applied for the MOH Allied Health Scholarship, which is now known as the Healthcare Merit Scholarship, and pursued my undergraduate degrees at the University of Sydney in Australia. So the picture on the left shows the Great Hall in the main city campus, but I studied in a specialized health science campus in another suburb out west. The course was 4 years long, and I graduated with a Bachelor of Applied Science in Medical Radiation Sciences for Diagnostic Radiography with honours. Here are some pictures from my student days in Sydney. There was a big Singaporean community in Sydney as well, which helped in the times that I really missed home. And I also played Ultimate Frisbee on campus and presented at a conference as a student as well. So as part of this specialized course in diagnostic radiography, we covered topics such as human anatomy and physiology of the body, the physics of X-ray production and the physics of different types of imaging, radiation and its effects on the human body, known as radiation biology. We covered psychology and sociology about human behavior, and most importantly, we studied about radiographic positioning, which covers how to position patients to obtain standard views of X-rays to appropriately demonstrate the anatomy of areas of interest. Also, we looked at the pathology of the various body systems. As this is a very hands-on practical course and profession, clinical attachments were a key component of the program. Over 3 years, we had 36 weeks of clinical placement in hospitals and clinics to practice our radiographic skills and also to improve our attention to patient care. The final year of my studies was an honours year dedicated to performing research, where I experienced the entire process of conducting a research project, from the beginning, coming up with a research proposal, to collecting data, doing the literature review first before collecting data, and then writing up a journal article at the end. And after graduating, I returned to Singapore to work at NUH. After working at NUH for almost 6 years, I decided that I wanted to further my studies by taking a master's in ultrasound. So I was first trained on the job, and I learned a great deal from my seniors and through self-study, but I felt that I would better benefit my patients with a greater understanding through a formal course. And I was supported by NUH through the Academic Medicine Development Award, and I obtained my degree from the University College Dublin in Ireland. So it was a challenging but interesting experience, as I was told that I was their first international student for their long-running ultrasound program. The major challenge that I faced actually was to find my own placement at one of the hospitals, and the school was not going to be able to help me in that, unfortunately. But thankfully, with some persistence, and also very thankful for my experience in scanning, one of the department managers accepted me for the attachment for the whole month course. So, like radiography, it was a practical intensive course where I spent most of my time at the hospital performing ultrasounds, and lectures and tutorials were held on only 2 days every 2 weeks. So that brings me to where I am today. I have been working at the National University Hospital since the beginning of my career. I started out being oriented in all the X-ray duties and performing shift work. I was very interested in operating theatre radiography, and I joined the OT core team, where I got more time in the theatres to hone my skills and also train new radiographers while they were on their orientation inside the operating theatres. So this allowed me to work closely with the orthopedic surgeons in the theatres and help to foster good relationships. And subsequently, I was tasked to set up this EOS low-dose X-ray service, which was sited in the orthopedic clinic itself. So at the time, this was the first system that was installed in Asia. And my role in setting up this service was to establish imaging protocols, service workflows, and also to train new radiographers how to use this system. So once the service was set up and running smoothly, I started my training in ultrasound, a challenging advanced modality that's very operator dependent and requires lots of practice for proficiency and confidence. And I have since been performing ultrasound scans for almost 7 years now, but I still perform general X-ray duties wherever I'm required. So I'm really happy to be part of the NUHS family. As a major teaching hospital, there were many training opportunities, not only in honing my technical skills, but also developing me and my leadership skills. I had many chances to work in multidisciplinary teams and many opportunities for bonding with my colleagues as well. So in addition to my clinical work as a radiographer, I'm actively involved in the professional scene. I'm currently the president of the Singapore Society of Radiographers, which is the professional society that represents radiographers and radiation therapists in Singapore. The SSR's aim is to foster a conducive environment of continuous professional learning for practitioners in Singapore to ensure that our skills and our practices can provide maximum benefit for our patients. We also work closely with the Ministry of Health and the AHPC to discuss some issues regarding radiographers that may rise to national levels. We also work closely with the hospitals and industry partners like our radiography schools and other companies that manufacture medical radiation imaging equipment. And we also collaborate with international organizations such as the International Society of Radiographers and Radiologists to contribute to the radiography resources and efforts worldwide. So the picture that you can see at the bottom left was actually captured during an online Zoom webinar that was organized by the ISRRT during the COVID pandemic. So this was a good platform where we could share our experiences in Singapore with radiographers around the world. More recently, the Ssr Students Chapter was established, and this is run by an all-student executive council, and we in the SSR main exco work closely with them to increase their exposure to professional society work and also to help them organize academic events and conferences. So these are some pictures from the professional engagements such as conferences and workshops. I've delivered some presentations at international conferences, and as the ISRRT Council representative for Singapore, you can see in the top left-hand corner, I had to vote on some motions that were proposed at the council meetings on behalf of the Singapore radiographic and radiation therapy community. Occasionally, we are also engaged by vendors to assist in delivering workshops as clinical specialists, as you can see in the middle here. So why did I choose radiography? Firstly, I knew I had an inclination to be in the healthcare industry. to care for patients, which really is the core of all the healthcare professions. It also helped, of course, that I knew somebody who was already in this profession and they could kind of introduce me quite quickly to it. I enjoy working with people and in teams, and I feel that I can contribute with this specialized skill set. To this day, it continues to give me great satisfaction in knowing that I can directly impact people's lives and their well-being for the better. Other pros of having a job in the healthcare industry include job security, because it is one of the essential jobs where we can always benefit from having more hands on deck. More hospitals and healthcare facilities are being built as we speak, and we will definitely need more radiographers in the near future. Singapore is also well positioned in the region as a medical hub. So with a world-class healthcare system, medical tourism was a thriving industry here in Singapore before COVID, but we are still seen as a leader in the healthcare system in the region, especially with our handling of the pandemic situation here in Singapore. And what about the bond period from the scholarship? Some people might be apprehensive to sign up for such a lengthy 6-year bond, but as a fresh graduate out of university, I knew I had a position secured for me, and I was grateful for the opportunity to be attached to a major teaching hospital in Singapore. In the first few years, I managed to hone my technical skills and improve on my soft skills, such as communication with colleagues and patients to provide quality patient care. Radiography is also most certainly not just a one-track career. As the field continues to expand, we need to grow our capabilities in education, research, and also administrative competencies. As with any healthcare profession, medical advances and changes in our population demographics and their expectations means that we cannot limit our understanding just to our technical knowledge. Exposure and experience in all of these other areas have definitely contributed to my personal development, not just as a radiographer, but also as a person. Of course, every line of work has its challenges. And during school, I actually found that the first year of radiography studies was actually a little dry. And I really wondered if this was what I wanted to do. But in sticking it out, I actually learned, as I learned more about the profession and understood more deeply about the advanced modalities and different technologies, I was definitely got more and more interested as the course went on. Time management and discipline is important in any stage of your study life. I found that this was especially true in my 4th year, as I had to manage my time and deadlines, as there were no scheduled classes. Learning to manage and plan your time is a great skill that you will carry on into your working life as well. So one of your key concerns about being in this line might be the occupational risks, especially with exposure to radiation and possible exposure to infections as a frontline healthcare worker. This is a very real challenge, but we are taught about radiation protection and infection control in school, and when we understand it better, then there is less reason to fear these things. All facilities are appropriately constructed with protective lining to protect ourselves as staff and also the public. And if we have to be in the same room, we will don protective gear like we saw earlier in the pictures with the radiographer in the operating theatre. So the National Environment Agency also regularly monitors each person's radiation exposure through a dosimeter. So I have one here, and basically it's a little chip that records how much radiation you get exposed to, and every 2 months we have to send this back to NEA, and they will do a reading and keep records for all radiographers that are issued with this dosimeter. So if the readings tend to go a little bit higher, they will actually do an investigation to find out why. Yeah, but the government is definitely looking out for us and our interests as well. The hospital will also ensure that as frontline healthcare workers, we have enough protective equipment that is made available for our use while we are on duty. So another challenge that I found was actually early on was to address the misconceptions that people may have of radiographers, that we are just button pushers. And of course, as a radiographer, I disagree. And I think I can also shed some light on why others might say so. So just for a moment, let's consider a vaccination. We know that dosages are very important. A stipulated volume per kilogram of a specific concentration of a vaccine needs to be administered to a patient for it to be effective. So this is then calculated for the size of the patient and then drawn up in a syringe and injected into the patient. So this misconception might arise from the fact that radiation is invisible. Behind pressing the button, radiographers actually have to calculate the appropriate dose of radiation required for each procedure and proceed to administer it to the patient to the right area and for the right amount of time as well. So each exposure that we make is a conscious decision, and because it varies with each patient and different types of pathology, every push of a button requires much consideration. So what does the future hold for allied health? Particularly for radiography, technological improvements will have a huge impact on our field in terms of our practices and imaging capabilities. Research into the applications of artificial intelligence have been gaining traction, and soon it will be a real game changer for the way we approach patient care and analysis of our images and our results. Last but definitely not least, as medical conditions become more complex to handle, there has been an increased focus on collaboration between disciplines to ensure that we provide patients with holistic care. Over the years of studying and working, I've learned that every day is a school day. There is no limit or end to what we can learn if we keep an open mind and a curious mind. It is an exciting time to be in the healthcare industry, and the future is definitely looking very, very bright. So what does it take to be in this line? I've put up a list of qualities here. If it sounds like you, then you may very well be suitable for this line of work. But even if you don't feel like all of these things describe you, don't worry. More importantly, at this time, when you're close to the crossroads of choosing your career or your specialized field of study, I would encourage you to take some time to explore both the outside world and to look within. What is it that drives you? What are your aspirations and your strengths? When you find something that you're keenly interested in, the decisions may come easier to you. And what is next? You still have some time to decide for sure, but perhaps it might be a good idea to look out for some job shadowing opportunities or have conversations with people about their work. When I was in your position, before applying to any programs, I actually wrote into Nuhs to request for a week-long observation visit to get a better idea of what radiographers do on a daily basis. The team at Nuhs kindly came up with a schedule for me to observe all the different duties and services that were provided in the department. So sometimes you have to dip your toes in for a first-hand experience to get a good idea of what any job might entail. So don't be shy to ask around. This brings me to the end of my presentation. Thank you for your attention. I hope that I've been able to shed more light on what a diagnostic radiographer does. It's not just about working with machines, but also caring for patients and contributing to the development of the profession as a whole. So please feel free to contact me if you have further questions or if you would like to know more about radiography. And I hope you enjoy the rest of the Healthcare Scholarships virtual experience.
Thank you, Denise, for sharing with us. So on that last part, I think it's true. So speak to someone whom you know about the discipline. Check out the various resources online and offline. I think there's COVID and there's lack of physical events, but I think there's no lack of virtual ones. So we shall go to the Q&A, and we have a few questions already. Maybe an easy one for Denise first. How do you find job satisfaction in your current working environment?
Job satisfaction in my current working environment.
Yep.
So one of the things that I enjoy about my job is actually the variety. So like I mentioned earlier, every day is a school day. There's always an opportunity to learn something new. So I feel that although it may seem like I'm doing the same thing day in, day out, like I meet different patients and I can make a difference in their day, one patient at a time. So long as I know that I've done my best for that patient, then that actually already gives me great job satisfaction.
Thank you, Denise. I think this sort of also answers the question on how do you get through the mundane job of taking so many X-rays a day. So I think I echo Denise's reply. If you go to a hospital, you will realize that there are different patients every day. I think you see different things. So I don't think it's very mundane. I think it's rather the opposite.
And one of the things that I realized as well is that it may be something that's repetitive for me because I come here every day, but for every patient, it might be a totally new experience. You don't come to the hospital every day, and if you put yourself in the patient's shoes, you know, what can I do to make this new experience, and sometimes a almost frightening or daunting experience to come to the hospital? How can I make this better for the patient? Yeah. And I think every little bit counts in that way.
Thank you, Denise. Okay, some other questions. Dealing with equipment and radiation, I think she has answered that in her presentation, so we will answer that. So there's one technical question. So will you be stuck to an advanced modality after finishing your training? Will there be opportunities for you to train in MRI, CT within your department?
Okay, so I think that differs from between departments. So I have a friend who's working in another institution, and just because of the way the types of patients that they see or the way the department is structured, they have a smaller team, so they're required to cross-train across several modalities. NUH tends to be is one of the bigger hospitals, and we have quite a heavy workload. So training does take time, and it's especially when you have a heavy workload, it may be difficult to train in more than one modality. Yeah. So in my current situation, I selected ultrasound, and mainly I will do ultrasound and then general X-ray. Perhaps in future there may be an opportunity to train with MRI, but at the moment we just choose one.
Thank you, Denise. Since you're on that, so there is one question which is, why do you choose to train in ultrasound instead of other modalities?
Okay. I actually was tossing between two. I actually was trying to decide between ultrasound and MRI. I think what caused me to gravitate towards ultrasound was I think the inherent challenge in performing ultrasounds, because it's a very operator dependent modality. So with MRI and CT scan, if you set a certain volume of, or if you set the parameters to take images between a certain distance, that you'll capture most of the information there. But in ultrasound, you really need to go looking for the pathologies and taking the appropriate images. So it's very focused, and it requires a lot of thinking on the spot as well. Yeah. So that was actually what attracted me to ultrasound more. Yeah.
Thank you, Denise. So one question which I think people get a lot, or maybe you will get a lot also. So what is the difference between diagnostic radiography and radiation therapy? Do both do both careers require exposure to radiation equipment?
So in our daily work, we actually don't get a lot of exposure to radiation from the equipment, because we have protective screens, protective glass, and the rooms are all lead lined to stop the radiation from getting out to the control areas. So this will be similar in a radiation therapy department. The main difference is that radiation therapy is for a curative purpose, and diagnostic radiography is for a diagnostic purpose. So most of the radiation doses that we use at a diagnostic level are much lower. So radiation therapy differs because we are using very, very high levels of radiation, but to target specific cells, which usually tend to be the cancer cells, okay, because we want to destroy those cells while preserving the tissues around, the healthy tissues around. So That is the main difference between radiography, diagnostic radiography and radiation therapy. Both require a different skill set. We use different types of machines as well. In radiation therapy, there's an element of planning. So that will be to create a patient treatment plan and to outline where exactly the tumor is that we need to treat while preserving the healthy tissues around. So the most important thing would be try to maximize the amount of healthy tissue that we can preserve. And they will use different types of machines. Of course, it's not my area of expertise, but they use like a linear. There's some new equipment that's coming in that known as like a proton therapy machine. So there are different types of machines that can treat that that are advantageous for certain types of cancers as well.
Thank you, Denise. So another few questions and we'll wrap up about 4:15. So let us have a more fun question. So the question is, having studied and done your clinical placements in Australia, do you see any difference as an HP working over there versus Singapore?
Any difference? Of course, your patient groups are slightly different. I think one of the main differences was, I think, that it was a little bit slower paced. I went to Australia and also to Ireland. So in Asia, like everything has to be efficient and go really, really quickly. So we tend to be busier here. But I try to bring back certain things that I've learned from developing rapport with patients back from Australia to here. It's usually easier when you have a little bit more time with the patient, but I've tried to use those, pick up from those skills that I've learned and try to truncate it into a shorter time so that I could apply it at the local level here, even though we have a very short time with the patient. Yeah, I hope that makes sense.
Yeah, I think that does. I should add on also, I think over the few days we had people from scholars and professionals from various countries, they studied there. I think the main difference is also here we have a very local context. So you have your uncles, aunties, your boy, girl. So it's very different from in Australia, I suppose. And of course, we have an aging population. So I think cultural differences are very real. And I think if you study in Australia, you will find that, there's that difference there. Even if you go and study in UK, there's also that cultural difference and that sort of thing. But I do think, although here we are faster paced though, I think the uncles, aunties tend to appreciate you more. I don't know, I might be wrong. I have never been to a hospital in Australia. But I think if it's an Asian thing, I think we all know where that's going. Uncle, auntie will give you a cake, will give you a sweet, will say you're very nice, uncle, you're very nice, that sort of thing. So I do think these are the differences lah.
Yeah, I think on the job also I managed to pick up very functional dialects. So very functional Hokkien, very functional Malay, just to be able to give them instructions. But the elderly patients actually do appreciate that a lot when they can see that you're trying to speak to them in a language that they understand. Yeah. So that was one of the special things about working here in Singapore.
Hey, thank you, Denise. Another question, and I think maybe we'll have one more after that. So the question is, how was your career progression like? How many years before you how many years before you undergo your ultrasound training? On top of clinical work, what other assignments do you have to undertake?
Okay, so again, this would depend. This would differ from department to department. Personally, after I came back, I did general X-ray for about 3 years before I started my ultrasound training. So during the time when I was doing my general work, I had this additional assignment of setting up the EOS X-ray service. Yeah, so that was sort of a new portfolio that I was assigned. It's slightly different from just doing the technical work because you have to come up with your protocols. You have to look at what documentation needs to be prepared when you set up a new service. You need to discuss how we want to set the protocols with the clinicians. So there were a few new things that I learned in the setup of that service. And then I went into ultrasound once that was stable. Ultrasound took a while for me to be trained up to what we would call, I suppose, advanced level. We have a basic and an advanced training. So the basic training took at least 4 months, 4 months on the job. Yeah, and every day still you'd have to practice to improve your skills and do lots of reading. And then it was only after I was doing ultrasound quite often for about 2.5 to almost 3 years, that's when I decided that, okay, I want to do a master's in ultrasound. Yeah, because I feel that I would benefit from a structured program. It would help me better link some of the clinical information with what I can see on my ultrasound screen. So that's when I decided to undergo my formal ultrasound training. And now that I am back, and I hold a senior position as well, so I am currently the second in charge of the ultrasound section. So there are other administrative things that we have to do to look at how we can best maximize our workflows. We have good workflow. We make sure that our patient throughput is good. We have to handle some of the patient feedback that comes in. I also do the musculoskeletal ultrasound training for my juniors. So I have to think of how we want to conduct that training. Usually we will stay back maybe once a fortnight to practice scanning on our own. Yeah. So there are quite a lot of things other than just solely clinical work. But of course, it depends again on what department you're in, what the department's needs are. Yeah, and then you can take it from there.
Thank you, Denise. We shall answer one last question. Are there rare cases that your team is unable to diagnose for a patient? What do you do then? I guess it's referring to if you look at the ultrasound, or you look at the X-ray, and you don't know what's going on. What does it entail in a hospital setting?
So the good thing about having so many different types of imaging is because they give you different information. So ultrasound, by nature of ultrasound itself, may not be able to give us all the answers because a lot of things can look the same or be described in the same way. So there are a multitude of other tests. We can do other scans that maybe give us different information. We can do biopsies if that's possible. Then we can actually have a look at the cells in the structure or the area of interest, and we'll see if that can give us some answers. This would really boil down to the multidisciplinary team already, because we're talking about trying to figure out what's going on in a patient, from combining their clinical information with the information obtained from imaging, with maybe information obtained from pathology. Yeah. So that's when they have things like multidisciplinary team meetings where they can all come together and discuss a case together and try to figure out, okay, what is happening in this patient. Yeah. So imaging itself might not give us all the answers that we need. It will certainly shed light on a lot of new things. It might give us new information, but it may not always give us the final diagnosis at the end. Yeah.
Thank you, Denise. I think we have now come to the end of the session with our speakers from NUHS. We hope that the information shared will be useful for those of you applying. Thank you, NUHS colleagues. Thank you, Bantong. We appreciate your commitment to our healthcare efforts. You may take your leave now. So we have now come
Thank you.
Thank you. So we have now come to the end of the session with our speakers from NUHS. We hope that the information shared will be useful. And if you have enjoyed this session, please take a few seconds to rate the program at the bottom left of your screen. Tomorrow we have an amazing lineup. We are having 2 panel dialogues about COVID-19 as our speakers share how and why they still dare to care amidst the pandemic. The first session is at 10 a.m. and the second one is at 5 p.m. So everyone have a great dinner, stay safe, and we will see you tomorrow. Thank you.